right. Well, thank you everybody for your patience. This session, I'm sure I have absolutely no doubt will be worth the wait. So we are very happy to be back now with our highly anticipated presentation on the surgical management of colorectal lung metastases with the renowned Dr. Marcelo Cypel. So those who are not familiar with Dr. Cypel, he is a staff thoracic surgeon at the University Health Network and a professor of surgery at the University of Toronto. Dr. Cypel is the surgical director of the Ajmera Transplant Center at UHN in Toronto, as well as the Artificial Lung Program at UHN. Now, during his postdoctoral research fellowship, he developed a new method of lung preservation and donor lung repair called ex vivo lung perfusion, so EVLP. And this method is now used clinically in Toronto and in many other centers, and it has significantly increased the number of transplantable lungs available. He subsequently performed a 3-year fellowship in thoracic oncology, cardiac surgery, as well as lung transplantation at the University of Toronto. Dr. Cypel currently holds the prestigious Canada Research Chair in Lung Transplantation from the Government of Canada, and he is the principal investigator in very innovative clinical trials, such as the in vivo lung perfusion with chemotherapy to treat patients with lung metastases that we'll be hearing about today. Finally, Dr. Cypel is an incredibly valued member of CRAN's Medical and Scientific Advisory Board, and it is absolutely my pleasure to welcome you to present with us today, Dr. Cypel.
Thank you. Thanks so much, Cassandra. Thank you for the invitation again. It's always a pleasure. I'm sorry for being a few minutes late. I just had to deal with an emergency. Let me share here. Okay, so I mean, some of you may have seen this presentation or parts of it. I'll try to give you maybe, at some point, some different flavor or what's coming up as well. But I want to really focus on this, local management of pulmonary metastases from colorectal cancer. We see many patients with this condition, and there are mainly 3 types of patients that I see, and we're trying to develop strategies for each of those 3 categories. So the first category is the patient that has like 1 or 2 lung lesions. They had the colorectal cancer resected. A year later, 2 years later, they present with 1, 2 lesions. And that situation is pretty straightforward. We can do like a minimal invasive surgery. We put a video camera, we resect the lesion, patient go home next day, and then we continue to monitor them. Maybe in a few years, another one shows up, we do that again. So that's the one spectrum of patient. And I like to say that because that's the situation where 95% of the thoracic surgeons would be in favor of doing surgery. Okay. Then there is the second condition, which is the patient that instead of having like 1 or 2 lesions, they come to see me and they have like 6 to 12 lesions, let's say. Okay. So that type of patient, for 95% of the surgeons, they will say no surgery at all. Okay. And the reason they say that is because the risk of having disease coming back is too high after surgery. And that's the situation where we develop the in vivo lung perfusion to try to improve the results of the surgery. That you remove those 6, 7, 8 lesions, you give a chemoperfusion of the lung. We're using traditional chemotherapy at the moment for that, and I'm going to talk a little bit more about that. And then there is the third category of patients, which is the one that come with what we call innumerable lung lesions. okay, or unresectable lung lesions. And that's a situation where surgery has never been part of the treatment. And that's a situation where, again, we're trying to find alternative clinical trials for those patients that would span from doing lung perfusion, less invasive with more effective therapies, or in a more extreme lung transplantation for patients that have only lung disease. So, I mean, this is just to give you a bit of an idea of the category of patients we see, and that's where we're trying to develop, better treatments for them. So the first, question is always, again, are the local therapies going to be helpful? So this is, again, a situation you have one lung lesions, and then it's pretty straightforward that surgery or other modality of local treatment could be beneficial. The other modalities are stereotactic radiation, conventional radiation, or other ablation techniques like cryoablation or radiofrequency ablation. And again, I'm going to talk a little bit more about, especially SBRT, which is the most used non-surgical approach. Now, we always consider when we see this, these patients, the age and whether they have other medical problems, because some of these treatments, they required, large surgical procedures, and so they need to be fit for that. Here we're only talking about colon cancer, but just to put in perspective, I do see many patients also with other cancers that spread to the lungs, especially sarcoma, some melanoma, breast cancer. It's very important to look at the timeline of disease. This is one of the most important features is, you had your primary tumor. How long did it take for the metastases to show up? Okay. So if they show up at the same time that you discover your primary, the prognosis is worse. If they show more than 2 years after your primary was treated, it's a better prognosis. And then we look at the number and location, and also if there is disease outside the lungs, right, lymph nodes or other organs. So in selected patients, local therapies are recommended. And surgery is the most established approach that we can do, as I mentioned, minimal invasive approaches, which make just small cuts. I did 2 patients yesterday, which was the situation where we just put the camera, remove a couple of lung lesions. They went home this morning. So tolerate very well. One of the advantages of surgery is that local recurrence is not common when you have appropriate margins. And when I say local recurrence, I'm not talking about new nodules coming in the lung. I'm talking about the nodule that you resected. Do you have cancer coming back in that area that you resected the nodule? Okay. It can provide long-term survival and provide tissue diagnosis. Sometimes it's important to look for confirmation or some mutation testing and so on. When you look at stereotactic radiation, there are also advantages. It is very well tolerated. Many patients don't need to stop working. They do that, take an hour or 2, they go back home, they come next day, they do it again. Minimal side effects, and does not preclude other treatments. There are some areas that are some challenge for SBRT. If the lesion is too close to the rib cage, they can cause rib fractures and a lot of pain. If they are too close to the airways, it can cause some narrowing of the airways, like the breathing tube, and that can cause significant symptoms. So not every lesion is suitable for SBRT. And it also can fail. I have several patients that I had to operate after SBRT failures. So this is one example here. You treat the lesion is in this size, and then 6 months later, the lesion is bigger. This is another situation, just that you have an idea, treated with SBRT, this nodule. And then here in 2017 is a normal scar that you would see with SBRT. That's what happens with SBRT. You have to be followed very carefully by an expert team because this scar tissue sometimes is difficult to know, is it just scar or there is still tumor behind, right? So that's one of the, I would say, disadvantages of the SBRT compared to surgery, is that sometimes it's difficult to know if the tumor is completely gone in that area. But I'll show you some data about what are the numbers really. And then 2018, this was bigger and more solid, and then clearly that was a recurrence and we had to do surgery. This is a patient that had a lesion here close to the rib, and she was not a candidate for surgery. She had SBRT, and then she had a crack in the rib here with SBRT, and she had significant pain related to that she had to go on morphine. So it's rare, but some of these complications can happen, but it's still a very useful adjunct therapy. Now, there hasn't been any randomized trial. We would like to start one here, and we're looking at putting that together, comparing surgery and SBRT. Okay, so what will happen, you see this patient that comes with 2 or 3 lesions, then you kind of flip the coin and say you go for surgery or you go for SBRT. That's what a randomized trial will do, and then we'll follow these patients and tell which therapy is better. So this hasn't been done, but there is a study that just compared the patients that had SBRT versus the one that had surgery for colorectal metastases. This is from MD Anderson, and that showed that the recurrence rate in colorectal cancer was double that the recurrence rate with surgery. And again, this is local recurrence, right? This is not more nodules coming, is recurrence on the previously treated area. So this number, I would say it's okay, but for SBRT, for most of the other cancers, they do get an 80-90% efficacy rate. In colorectal cancer, we're getting about 60%, right? So it is a tumor that is more resistant to high-dose focused radiation than other tumors we treat in the lungs. Now, we always meet as a group to decide, what's the best treatment. And when we would decide not to do surgery, so if a patient has a lesion that is in the middle of the lobe and I have to remove the whole lobe to remove the lesion, and in a patient that I think may have disease in the future, that is a patient that may be better to do SBRT to spare the lobe, okay? If there are lesions, multiple lesions where we would be able to do minimal invasive surgery, if some of the lesions could be treated with SBRT, that will do what we call a hybrid approach. And if a patient has multiple medical comorbidities, we may consider doing SBRT. Now, in terms of the general principles, this is still, I would say, quite current. And, for patients that we do surgery for colorectal cancer, the 5-year survival rate is about 40-45%, okay? So those are the patients that are selected to go on for surgery for pulmonary metastases, okay? So, that's not great, okay? But as I'll show you, it's certainly better than if you don't do surgery and stay on systemic therapy. Again, even though there is what we call some selection bias on that. Now, when you see here R1 or R0, meaning that, if you only, let's say you have six lesions, and you say, well, I can only resect four of those and I'm going to leave two, okay? That's much worse than if you resect all of them, okay? What we call the R0 resection, okay? So it's very important that we treat all the lesions. If you can't remove all the lesions, then you should do SBRT for the remaining ones, okay? The number of lesions is important. So if you have more than 3 lesions, the outcome is worse than less than 3. And there are other prognostic factors. And here it shows that when the risk ratio is above 1, means that is a higher risk. So male has slightly higher risk. And if you have extrathoracic metastasis, most of the time liver metastasis, it's slightly higher risk, but it's not much, okay? So a patient with colorectal cancer, if they show up with lung and liver metastasis, to me is exactly the same if they show up with only lung metastasis, because the prognosis, it's not altered by the fact that you have liver metastasis. It's like a minimal increased risk, okay? What it really does put you in a very adverse prognosis for surgery is if you have lymph node metastasis in the mediastinum, okay? So these are lymph nodes that run around our windpipe here, and sometimes patients with colorectal can present with those, okay? And one feature that is protective, as you can see here, is if you do repeated surgeries, okay? That's a protective feature. But again, this is somewhat biased because we only do repeated surgeries in patients that have limited recurrences that we think we can remove the whole disease. So, I do have patients that I'm doing surgeries now for 8, 9 years. But, I remove a couple of lesions here, and then 2 years later, they show up with one more, and then I do surgery, and then 2 years later, they show up with two more, and then we do surgery, and then 3 years later, they show up with more. So, that patient has a disease biology, which has allowed us to do this more aggressive approach, if you will. Again, here is just showing, again, if you do repeated surgery, you do better, but it probably, again, reflects a combination of the procedure and the type of the patient and the biology of the disease. Again, some centers, they don't recommend surgery or SBRT at all if you develop pulmonary metastasis. So, we see even patients coming from other Canadian provinces that they were told that there is no recommendation for surgery. And then when I see that type of patient, I expect they have like 20 lesions, and I see them, they have like 2 lesions. And they were told that there was no indication for surgery, right? And some centers or some surgeons are skeptical because there haven't been what we call a randomized trial comparing surgery versus just staying on chemo, right? The only attempt to do that was a clinical trial in the United Kingdom that was powered for 500 patients, and they basically couldn't recruit patients because patients didn't want to be randomized to the non-surgical arm. So it's very difficult to do such a study to prove that concept. And many things in medicine, we do the treatment without randomized data, but with other types of level of evidence and retrospective studies looking at the outcomes. As I mentioned, we do discuss every patient in our clinic here. And we have surgeons, radiation oncology, medical oncology, and the thoracic radiology. And I like to point out the role of the thoracic radiologist because especially, again, for CT scans that are done outside our center, Many times when we look at the images, we'll see different results that actually the report says. And so patients refer to us for, two lung lesions, and on the report, we look at the CT, we actually find 6, 7, okay? And so that thing change a lot what the treatment will be. Just again, a few examples. We sometimes it's a 76-year-old colorectal cancer resected 2 years prior, and then presented with 3 lung lesions that I showed you here. And so this is a situation where we decided to do a combination of SBRT in one side and lung surgery VATS, minimal invasive on the left side. And you can see here, as I mentioned to you, this is the scar of the SBRT. This is the scar of the surgery. So you can clearly see here, then if a tumor comes back in this area, you'll be able to see quite well. But if it comes back here, it may be quite blurry to be able to determine, okay, because of that scar. This is another patient. Also, we did a combination treatments. And so both surgery and SBRT have good local control. Surgery has a better local control. I mentioned 80% versus 60%. They have low toxicity. We haven't had a randomized trial to completely confirm that surgery is better, but most of the data indicates that. And the patient selection is really the most important. Now, there is also, I want to show a situation where, a patient would be deemed as non-surgical candidate, and sometimes being evaluated by a center of expertise is worthwhile. So this is a young patient that had colorectal metastases, only 1 lesion, okay? And he had his primary tumor a few years back. So this is from a biology of disease, is the ideal scenario to do lung surgery. But if you look at the location of this, is right in the middle of the lung. So the left lung, this is the left lung. The left lung is divided in 2 lobes, and this is in the middle of the 2 lobes. So the only operation here that would be feasible in theory would be to remove the entire left lung. And so this patient was deemed as a non-resectable patient because we really don't like to remove a complete lung in that situation, because leaving the patient with a single lung, there is some impact in quality of life, but also if they present later with lung lesions on the right lung, you don't have any options, right? So we looked at this very carefully, and because we do have more advanced techniques, we decided to remove the lung, but then take the tumor out when the lung was outside the body. We call it an ex vivo tumor resection. And then, so this is a chest here without the lung. These clamps are in the vessels of the lung. And then basically what we did after removing the tumor, we did what is called a auto-transplantation. So we just put the lung back into the patient, and he recovered quite well. So you can see here, this is the windpipe. We're connecting to the lung again, and we did same for the vessels. Again, in a center that has a lot of experience with transplant, this is a technique that can be feasible as well. And you see his X-ray here. After, you can see that a good portion of the left lung is back there. Otherwise, he wouldn't have a left lung. Now, as we discussed, the main reason why surgery often fails when you have too many lesions is because you have this micrometastasis. And these micrometastases, they are directly related to the number of lesions that you have. So if you have, again, 1 lesion, the chance that you have micrometastasis is much lower than if you have 6, 7 lesions. You probably have additional 6, 7 that you can't see it. Okay, and that's why you do the surgery and more lesions show up later. And this is the rationale for us doing the in vivo lung perfusion. This was derived from this technique, as Cassandra mentioned, that we developed here, which is called ex vivo lung perfusion. This is a human lung outside the body being treated prior to transplantation. And so what we want to do with the in vivo lung perfusion is exactly the same. Treat the lung, only the lung, but not taking the lung out of the patient, but separating the lung from the body circulation. And so this is where we started developing this technique. This is the first studies we did still in large animals to kind of develop the method. And then after a few years of studies in the lab, we first started with sarcomas. The reason I started with sarcoma was because most of the patients with sarcoma with lung metastases are very young patients. They are majority in their 20s or 30s. And I said, I felt that, let's use the, healthier patients to apply this technique first, in case there are more complications and so on. And most of the patients, if I look back 10 years ago, most of the patients that I used to see with colorectal cancer were patients in their 60s, 70s, right? And things changed completely, as you know, and now we see a lot of patients in the 30s and 40s with colorectal lung metastases. And I think there is a lot of media talking about these days, how this disease became a disease of much younger, patients. And I can clearly say that that's my clinical impression as well in the patients I see. So then we moved on to colorectal. And again, first, we had to study the drug that was effective for colorectal, oxaliplatin, because sarcoma was a different drug. And we did this initial studies to determine the dose. And we could see that, when we get to 80 milligrams of the dose, then it was too much. And this helped us to determine the design for the clinical trial. And so this is the design of the clinical trial. We went from 5 milligrams all the way up to 40 milligrams. So this is not completely updated. So we went all the way to 35 milligrams. We didn't see any toxicity related to chemo. And then we did 3 patients at the dose of 40 milligrams. And in 2 of those 3 patients, we saw some what we call lung inflammation related to the chemo. Okay. And so because of that, we were about to move already to the next phase trial. We had to step back and do 2 additional patients at the level of 35, which I'm doing tomorrow, the next one. But that was a request by Health Canada to say, well, you did the 40, you saw some toxicity. We need to be certain that the 35 is indeed okay. And that's why we're expanding that group still as part of the phase 1 trial. Okay. The patients eventually recovered well, but they had to stay in hospital longer than the patients from the trial in general. So again, this is the technique here. We keep the lung inside the chest, so we don't take and put in the machine, but we kind of separate the lung from the heart with these clamps. And so we can infuse the chemotherapy. And one of our main goals now is also develop less invasive techniques for this. so that especially for patients that were going to develop therapies that you can apply without removing the lesions, it will be much better if you can do that without having to have an operation. And these are the type of scars that you get on both sides of the chest. This is a typical patient. You can see here, we do surgery in this case on both sides to remove the lesions on both sides, but we only did the chemotherapy to the left lung. So you can see the left lung is a little bit more hazy on the first day, but that is not chemotherapy toxicity, okay? The chemotherapy toxicity only starts down day 3 or 4, okay? This is just because we did the perfusion of the lung. And that clears up very nicely on day 2 and 3. And again, most patients then go home around days, between day 5 and 7. Okay. This is a example of a patient that shows that perhaps this method really can have an important application. So he had 2 lesions on the right side and 7 on the left. Okay. And again, when you look at 7 lesions on the left lung, this will be considered non-surgical candidate, right? By the most of the standards. And so we did remove the 2 lesions on the right and remove the 7 lesions on the left. And then we did the chemotherapy on the left side with IVLP, okay? Then 6 months later, this patient presented with a recurrence just on the lung that we didn't give the chemo. And we went there and resected that, okay? And now this patient is 30 months without any recurrence in the treated lung, okay? So I haven't seen in the past any patient that I resected, 7 lesions in the lung, and I haven't seen recurrence before, okay? So, again, this patient maybe has a, better response to chemotherapy. Again, he has been off chemotherapy since the surgery, so it's not that he is on treatment, but maybe even the chemoperfusion, he is more sensitive to the effect of the chemo to kill micrometastatic disease. And we do have other patients that are in the same track as this patient, okay? Here, just to give an idea of the age, going back here. Like the mean age about 45, 2/3 male, 1/3 female, and that's the average number of lung metastases was 9. Okay. And again, the length of stay in hospital 7 days as an average, and then some patients have distant recurrence, and then some patients had recurrence. I would say many patients still had recurrence, but we did see a reduction in recurrence in the treated lung compared to the non-treated lung. This is data that we're still following, of course. The tissue concentration, so we measured the oxaliplatin in the lung, is totally related to the dose that you give. And what is very important is that when you measure the blood of these patients, there is absolutely no detectable chemotherapy in the blood, which means that they don't develop any side effects related to the chemotherapy in the body. Okay. This is a video of the procedure. You can search for that on this website. It's open, freely available, called Toronto Video Atlas. If you don't just put in vivo lung perfusion, you'll be able to see that those were one of the first cases we did. Things have changed a lot in terms of how we do the technique now. Let me see how I can pass the slide. Ooh, completely took me off my presentation.
I can
But
confirm that we're seeing the YouTube.
yeah, yeah, I
Cypel.
know I
Yeah.
did that. Let me stop here and
Yeah, no problem.
let me, I think it's some sort of hyperlink in the
Yeah.
presentation. Okay, let me share again. Okay, I think we're back, right?
Yes, that looks good.
So as I mentioned before, there is a third scenario, which is the unresectable patient. That means there are too many lesions. We can't do surgery or IVLP. And generally speaking, the outcomes of unresectable lung metastases are not great. I mean, there is now hopefully better chemotherapy, other systemic treatments. Some patients respond to immunotherapy. There are other targeted therapies. I think these outcomes are improving. And based on our team here developed a program to do liver transplant for patients with colorectal liver metastases when they couldn't remove all the lesions. And so we felt that, if this has been successful for liver, why we can't try in lung? And this is one of the larger studies because this was, again, it was a randomized trial. And they basically randomized patients to either stay on standard of care treatment or they would go to liver transplant. Okay. And of course, there is a selection criteria for that you have to fit. And when you look at the outcomes of the patients was dramatically different. So if you stay on, standard of care, your, 5 year survival was about 10%. If you did liver transplant, your 5 year survival was 75%. So huge difference. Now, many of the patients that had a liver transplant, they also had recurrence in the future, but they were still alive at 5 years. Okay. So I have done surgery in the lungs in patients that had a liver transplant for colorectal cancer 3-4 years ago. And now they have a lung nodule and we go and do surgery. Okay. But it would be amazing if we could achieve similar results in lung, right? And that's where we want to try. Again, when you look at situation like that, you have to be selective in the patients you do because especially with transplantation, you go on immunosuppression, right? So immunosuppression basically take all your defenses against cancer down. And you have to be sure that you're removing completely all the cancer that is present in the body. So if you have lymph nodes involved or if you have other organs involved, then this technique cannot be used. It has to be truly for patients that had only lung disease or liver disease. So this is kind of the criteria that we're using now. Age less than 65 and patients that don't respond to immunotherapy, they are unresectable, they don't have extrathoracic disease. We do sample mediastinal lymph nodes and they have radiological response to systemic therapy. So that's where we are now, and hopefully we'll be able to recruit patients for this in the upcoming couple of years. I don't really know what to expect, to tell you the truth. It's really something that never been done before. We do very rarely do lung transplant for lung cancer patients, but that's a very different scenario. Those are patients that had the cancer originating from the lungs. So it's a different disease, right? So this is just our thoracic surgery group here. I know I see many of the patients with colorectal cancer, my colleagues, they also do this type of surgery. And I would like to finish here and happy for any discussion.
Thank you so much, Dr. Cypel, for sharing your groundbreaking work with us and with our audience today.
And sorry, Cassandra, if I can also mention that, we are working in the lab with some therapies for IVLP that are not chemotherapy. At the end of the day, I don't think chemotherapy is what's going to do the trick here. I think it's going to be more biological type treatments like gene therapy, combination of gene therapy with immunotherapy. And that's what we're working now in the lab to try to develop those.
Can't wait to hear more about it. What we'll do now is we will head, Dr. Cypel and our coaches can head backstage and we can have that interactive discussion. Again, for our audience, we're doing this to ensure that our coaches have, a really good opportunity to develop the content required to support you throughout your colorectal cancer journey. So just using the button in the bottom right-hand corner of your screen saying enter backstage for the coaches, you can go ahead and Philomena and I will meet you there. In the interim, I'm just going to bring my screen back up here. Okay. All right. So this brings us to the end of day 2 of my colorectal cancer summit, and what a day it has been. I will very shortly pass it over to Philomena to provide some closing remarks, but I just wanted to end with a little quote, and that is that cancer is only a chapter in your life, and it is not the whole story. So I wanted to share that for the patients and their family members that are watching today, who are really living with this disease or living beyond this disease. Just before I pass it over to Philomena, I will take a moment to express our appreciation to the summit sponsors, Masters Insurance, Natera, Pfizer, and Taiho. Thank you very much for your generous support that allows us to bring this wonderful, wonderful patient education to the colorectal cancer community. And with that, on behalf of CRAN, thank you so much for joining day 2 of the summit. I will pass it over to Philomena to provide closing remarks for the day. Over to you, Phil.
Thanks very much, Cassandra. And that was a lovely quote. So hello, my friends, and thank you. Thank you for having joined us today. A particular vote of gratitude to our event sponsors, without whom this summit would not have been possible. Natera, Pfizer, Taiho, and Masters Insurance. We are truly grateful for your unwavering support, and a heartfelt thank you to a stellar lineup of experts who delivered content on the surgical management of colorectal cancer, including ostomy care and colorectal lung metastases, as well as experts who delivered presentations on coping skills, supporting sexual health, and nutritional recommendations. We noticed that these sessions were nicely populated, nicely attended, and not surprisingly, because this is content that is of great relevance to patients and their families. I invite you, ladies and gentlemen, to tune in tomorrow morning, as we will be exploring topics such as the medical management of metastatic colorectal cancer, which includes the role that biomarkers play in helping to inform clinical decisions, the surgical management of peritoneal metastases, interventional radiology treatments in managing metastatic disease, the difference between PET, CT, and MRI, and why inclusivity is so important in cancer care. It's going to be a fantastic lineup of expert presenters. Of this, I can assure you. But till then, my friends, I wish you a lovely evening. Good night.